Trauma Verification's January Q&A web conference. For best sound quality, we recommend that you connect to audio by phone. If you're not currently connected by phone, look at the GoToWebinar control panel on the right-hand side of your screen. Select audio and then select phone and dial into the number that appears. And now I'd like to introduce Molly Lozada, Trauma Verification Program Manager.
Hello, everyone. Thank you for joining today's webinar. And we're going to go ahead and get started. So it'll be just me today doing the presentation. And just some housekeeping items that we're going to go over. To qualify for CE, you must attend at least 15 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim CE. If you have any questions during the entire broadcast, please email us at cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS Trauma Verification site visit, and how following these will positively impact the quality of care of the injured patient at your center. So with that said, we're just going to get started. Just some items that you will want to have on hand if you're new to our webinars. You want a copy of the Orange Book or a copy of the PDF just so you can refer to any criteria that are referenced through this presentation. Again, I want to stress the importance of downloading the most current copy of the clarification document and verification change log. I have learned doing this over time that some folks think there are various versions of the resources manuals out there on the website and even in print, but there are not. The copy that's available to everyone printed or as a PDF copy is the original one that came out in 2014. So any changes to the manual regarding a criteria or a clarification needed, it's going to be on the actual clarification and the verification change log documents. Those are maintained monthly, and a monthly email is sent to all our participants and our reviewers, as you can see here. This is just a quick snapshot of what the clarification document looks. It does look different than the change log. Again, just recently we did this, I believe, in within the last month during the last webinar as well. We shortened the clarification document because it was extremely long. So we are only, if you will notice that, we only kept those requirements / criteria that had a clarification to them. Anything that did not, we removed from the document. So it's a much more condensed document. Here's the verification change log. One of the things I do want to add to this is that this document can be downloaded as an Excel file, and as mentioned before, you can filter it by any of the columns present. I have received some requests about gap analysis for level 3s who are interested in going to a level 2 and or level 2s going to a level 1, or a new trauma center that's just wanting to get in the process. And unfortunately, we don't have a gap analysis per se, but ideally, this is one document you can use to actually do a gap analysis, and you can, again, you can filter it as you like. The webinars are recorded during the session and will be posted within 1 week of the ACS YouTube channel. You may access those through the VRC resources webpage link as you see here. And please scroll towards the bottom of the document or the webpage. It is a little bit long. We are going to condense that and have its own menu link soon to just house the webinars. All questions are pulled directly from the questions that are submitted through the portal. There have been no edits made to the contents of those questions. If your question is not answered today, the question may require more information and will receive a response from the ACS staff within a week of this webinar, or it also can be due to duplication in in one of the other questions. Some announcements. The next verification Q&A webinar is scheduled for February 22nd at noon Central Standard Time. The deadline to submit any questions will be February 9th, 2018. Just an update on our resources revision process. As you all know, Chapter 6 is completed, been approved. None of these will be released at this date. I know there's a question somewhere in the webinar that asked about when will the book be released. We have not established a timeline of that. We are working on each of the chapters one by one, and we are working on them concurrently, and we'll have those approved before anything final is released to trauma centers. I have talked about the plan. Some of you know about it. The plan is that when all chapters are finally approved by the executive committee, we will have a date when they will be released, when the manual will be released, and trauma centers will have a period of time, say a year, to implement and review those changes. And then following that year, trauma centers will then be surveyed on the new standards. So there is a plan in place that we will be working with trauma centers that will be surveyed under the new standards. When that time comes, we're not there yet. We're looking at possibly within an 18 month to a 2-year process at the present time for the book to be finalized. So it's a fluid timeline, so please don't hold that against us. So again, it's a fluid timeline, and it can change at any point in time. So again, we did 6. We're just now met with Chapter 9. 10 is almost done. And 15 is about to kick off this week, so we are making some progress. And Chapter 19, again, that one is almost done along with Chapter 10. Just again, to housekeeping, just reminders, there's some resources for trauma program managers and trauma medical directors who are new to our process, so feel free to visit these links. I mentioned this before, we have a trauma quality program participant hub. The website is here, and it is a hub for all trauma program managers or trauma medical directors to go and access your account, and you can update your contacts, and you can manage your facility information. And if you need to submit data or review data reports, that's also on the participant hub. If you no longer are the primary contact or require login assistance, please email the tquip@facs.org website or link here, and someone will provide you login access. Just some scheduling reminders. Again, the applications must be submitted 13 to 14 months ahead of when you want the visit scheduled. Rachel is currently accepting applications for November and December of 2018, so there's still some slots available, and of course 2019 is available. Just keep in mind that we do have some high volume months to keep in mind when you're requesting a site visit. So just keep that, be informed. Providing trauma quality program updates. I mentioned this last month during our webinar, and we've seen a lot of changes with the staffing at some trauma centers. As you all know, you have to submit your application about 1.5 years ahead, as you know, and there are changes that occur. The challenging aspect for my team on the reporting end of it is that when we do release the final report or have questions about your site visit, following your site visit, and we need some data, just to clarify some data or some information, we don't have the most current trauma program manager, trauma medical director. So please let us know either through the participant hub website if there's been a change, or you can email us at either the tquip@FACS or the COT at FACS, I'm sorry, the VRC COT at FACS email, and let us know what those updates are. because there have been some challenges. And I do want to mention that on the site visit application, if you can note your credentials, MD, RN, EMT, NP, PA, I mean, that is very helpful when we address the letters to back to you in our reports. Again, this is talking about the OTL form for new trauma centers that have not been through our process, or this is your first review under the new manual, which we're going into our 4th year now. So if you're a new trauma center, a new level 1 trauma center, a pediatric or combined trauma center, make sure that you complete that OTL form and submit that with your site visit application. The form is posted on our webpage here, as you can see. For those trauma centers that have already undergone a review during the past 3 years and completed an OTL form, you're not required to complete another form if there has been no change to your orthopedic trauma leader. So if it's the same orthopedic trauma leader, we have that on file, but we do want to ask you to if you have not done this yet, when you submit your application, just let us know that there's no change in your OTL leader and it's the same person, and just note their name, and we'll just go ahead and confirm that. Thank you. And if it's a new OTL leader at your trauma center, then you will be required to complete another form. So Anita would definitely follow up with you following your application. Just a quick overview of the alternate pathway criteria. This is something I get questions all the time. The alternate pathway criteria is only for foreign trained physicians. It's not applicable to any physicians who completed a residency here in the U.S. or in Canada. If they went to medical school abroad and then finished their residency here in the U.S., they're still not able to do this. Again, we're just primarily speaking about those that did a residency and are board certified abroad. So if you have someone on your trauma panel like that, and they have never gone through the alternate pathway and been approved, I highly recommend you do that at your earliest convenience, because it is a process that they have to, not only that they would have to meet, but also what Rachel has to do to get that person vetted through our specialty group, that being the orthopods and the neurosurgeons. So again, just take into consideration there is a time lag on that, and securing a reviewer to do an on-site visit is just as challenging as getting the 2 trauma surgeons on a team. For a copy of the list of the criteria, you can go on our website, as you see here, and it will go into detail about the criteria needed for the alternate pathway. Access to your PRQ for those new trauma centers, just coming on for scheduling. You will get your logins in the email sent by Anita. If you scroll towards the middle of the document, you'll see them. You can access that. Once you have access, you can access it at any time. What's not on here is just really a quick tidbit, is that do not leave it idling. The website, don't leave that idling. What happens is it will time out on you, and any data that you have not saved will be lost. We have updated all the documents on the web page in Word that will match your PRQ. And again, be cognizant of the type of patients that your trauma center admitted, because that will impact the type of PRQ and the type of questions that will be displayed to you. So if you're an adult trauma center and you do not admit any pediatric patients, then that's the type of Word version you want to download and what you want to select as your PRQ. If you do admit any pediatric patients, whether that's 5, 10, 100, 150, please be sure to select the adult and children's version. Do not submit payment with your application. You will be invoiced. An annual fee, a trauma quality program annual fee, which includes the yearly fee for the verification visit and also for your TQIP participation fee. And that bill will come anywhere between 60 and 90 days prior to your scheduled visit date and or anniversary date. Again, just as reminders from Rachel, visits are typically scheduled within 90 days. Sometimes it's sooner. There are some times or some instances where there are some challenges, especially if it's a combined trauma center. Getting a team together can be a little bit challenging. And I know she has ideally on here, but we do make an effort to schedule all site visits during the preferred time that you have established for us, and definitely before your expiration date. Again, Rachel will let you know when there are firm dates with the lead reviewer. She'll email you those dates. I did talk a little bit about a pilot that Rachel is conducting, and what that entails is that she is sending out, and you probably have been notified about this, we're kind of narrowing down the 90-day gap here, because we do look at all the feedback, and I know some trauma centers, there's challenges with securing a meeting room and getting people for the date of the site visit because of vacation, graduations, and so forth. So we are aware of that, and one of the things that Rachel has done is implemented this pilot program, if you will, and we have gotten really some really good feedback on it. And basically, it's just we're working off the dates that you would provide us. Basically, if you want us to come in January 2019 and just tell us, I want you to come in January 22nd, 23rd, that is what we're going to schedule your visit for. So again, it's a pilot. I'm sure she's reached out to many of you, so just be on the lookout for that, we are going to be possibly transitioning to that format here in the near future, because it seems to be going really well with the hospitals and also the site reviewers. Preparation for site reviewers. We do get a lot of questions about this, and again, this is just a reminder for those of you trauma centers that are having a site visit in the next couple of months. Travel arrangements are made by the ACS travel agent. So if you want a copy of those flight itineraries, please reach out to your site reviewers. Their contact information will be in the email Rachel sends you confirming the site visit. We do not get a copy of those itineraries, so make sure you ask for that. Again, the hospital will arrange and pay for the site reviewer's hotel accommodations for the first night. If you happen to have a reviewer that's coming from West Coast to the East Coast or vice versa, or for whatever reason there are some challenges with travel for that particular reviewer, because he or she may be coming from a rural area and may need an additional night of lodging, ACS will pick that fee up. If you can just let us know, because sometimes the reviewers will just go back to the hospital and not let us know that they need an additional night of lodging. So again, ACS will arrange that and pick up that expense. So again, if you are preparing for a site visit in the near future here within the next couple of months, please be sure to contact your reviewers, not only for travel arrangements and pickup at the airport and so forth, but also in preparation for your site review meeting. If you're doing electronic, if you're doing EMR charts or paper charts, you want to have a conversation with your reviewers to ensure that you have what they need to get to do the review. You don't want to have any surprises when they get there, so you want to make sure you have a conversation, whether via phone or email. Just ask them, let them know you have an EMR, you're going to have things tabulated for them, and what all that involves, so they're aware of how your setup is at your facility. So we're just going to get started with some questions here. So I had a question about PRQ and tibial washouts. The question asked, does an informal washout in the trauma bay count as a washout when presenting data to the ACS via the PRQ? We have to report an average time to washout of open fractures. I'm just trying to clarify what the definition of a washout is for those standards. If the wound is cleaned out in the trauma bay and splinted, then taken to OR later, does that count as the initial washout time? Or does the washout have to be a formal pre-op washout in the OR in order to be captured for reporting? It is the latter. So the way we've defined this, and again, this is also in the clarification document, time to first operative washout of open tibial shaft fractures from present that presented to your ED. So it's a time to formal OR washout. So that is the definition. So there's this little gap there. ACS consultation visit. Does the ACS recommend having a consult visit prior to verification? We get this all the time, and the answer is no. It's not a required type of site visit, so we do not mandate that, but however, we do recommend that having a consultation visit prior to verification for new trauma centers that are seeking a verification for the first time, or for even an existing trauma center that may have had significant changes in the program with personnel or even changes in your PI process. So having a consultation is not required. That is something that you as an institution will determine if that would be beneficial to you having that. And I will say this, because again, it's one of these questions that we get asked a lot, is if you have a consultation visit, can you flip that around and have a verification like right after? And you know, the answer is really no. If you're it's the same kind of visit, it's the same process for a consultation that it is for verification. So the time that it takes to prepare for that, you're going to need that for the verification visit. So ideally, we like to see a year to a year and a half in between the two types of visits. So with that said, I do want to stress that there are several state statutes that require trauma centers to have a consultation visit prior to a verification visit. So I strongly urge you to check with your designating authority to ensure that you're in compliance with your state process, because that certainly will impact your verification going forward. If it's mentioned in the H&P and or the discharge summary that a surgical service was consulted and recommended non-operative management of an injury, but there is no written electronic consult note by the surgical specialist, can we still count this as a consult? So it can still be counted as a consult. However, a good admission, H&P will often document the process of care and the injuries. So that is what the reviewers will be looking for when they come on site to looking at your cases. You want to make sure you have documented information in there. So by not having that, it makes it that much challenging for the reviewers to review your PI process on that particular case. So again, you want to be cautious of that not happening on a lot of cases, because that can be cited as a weakness. Performance improvement. What is the most important aspect of the performance improvement process that the surveyors will be looking for? What does good PI look like? And this is really what I have here is what the reviewers will be looking for in a case review. Now, how they go about it may differ, but ideally, this is kind of a standard practice that reviewers do, and this is how they write up their charts, to be honest with you. If you look for those trauma centers who've had a visit before, this is how they identify the case reviews in the back of the report. The most important aspect of the PI process is the documentation. We can't stress that enough. I mean, you know, we can't follow your PI process if there's nothing in writing. We don't take anything verbally. It has to be documented. And whether, so going back to this question, the PI process is documentation, and whether issues with a case, i.e. delays in care, urgent care, or anything that's, was flagged, were identified. And if there is something identified, how was it identified? What is it? How did you get to that? Was it a routine audit? Was it a report by a nurse? Is it a patient complaint? We want to know how you found that, what the initial investigation consisted of, who the issue was presented to, and what the recommendations were, and what is the corrective action or the loop closure, with a loop closure. So in cases with an issue and that underwent PI review, have the PI record attached to that chart, or have a flag to direct the reviewer to the EMR PI record. This will demonstrate a tight PI program. So again, this is what the reviewers are looking for. They want to know if there was a PI issue, how was that identified? How did you catch it? What was the outcome? Was there any recommendation, any corrective action, and what's the loop closure on that? So Again, this is really what PI should look like at your trauma center. But again, it could differ. We're not saying this is just one way of doing it. Evidence identification and review. What type of format do the reviewers prefer to see the evident resolution of cases? As I mentioned in the previous slide, that is how they want to see the PI process. But reviewers like to see a spreadsheet. They can, again, this is one way. I'm not saying this is a definitive way. I'm just making some recommendations here that reviewers like to see a spreadsheet with columns titled, and again, the titles are, you can change the titles here, but corrective action plan, responsible person, and evidence of loop closure, or headings along those lines. Again, you can call it what you want to call it. If your PI process did not find an event, tell the reviewers how you found the event and the likely reason this did not pop up during your audit. So again, you want to be honest during your review process, because if the reviewer finds it, then that's going to create some dialogue at the on-site visit. If you disagree with reviewers as to whether the event was whether it was a significant event, just ask them to explain their reasoning and discuss in a civil manner. I'm just stressing what's in our exit interview here. A contentious discussion will almost certainly be indicated in the report, because we have to track that as well as part of our PI process. So if there was any discussions regarding an exit interview that just didn't go as planned, and there was some discussion following the exit interview, the reviewers will definitely note that in the report, and the chairs will take that into consideration, and we'll review that with the on-site reviewer. So just keep that in mind. Orange Book revision, as I mentioned earlier, I had a question about this. Is there an anticipated date for reviewing the new purple book draft? I love the color suggestion. Thank you for that. I will keep that in mind. There is not an official release date. As mentioned early on, only one chapter has been completed. There are a couple of chapters that are tentatively in the process of completion by March. As I mentioned, that was chapter 10 and chapter 19. Hopefully those will be completed and approved at the March meeting. But again, these are fluid timelines, so just keep that in mind. Past webinar slides, we had a question about, can you make a book out of the slides from the webinars and organize them by Orange Book chapter? You know, presentations from past webinars may be released upon request, and we have done that. We are in the process of having these presentations available on the VRC webpage resources right next to the YouTube video. So we are going to be meeting to discuss how to go about that, but we will have those available for folks. So if anyone's interested in past webinars, or if you want all the past webinar slides, we certainly can release those to you upon request. Peer review minutes, how to handle review of peer review minutes when the physician is absent, electronic okay with read receipts. Besides your call panel, who else should get the peer review minutes? Just a couple of questions about those. So response to question number 1, how to handle peer review minutes when the physician is absent. This will vary by institution how that's disseminated. A secure, you know, you can do it with a secured email with a read receipt, that's acceptable. However, just keep in mind that that will not count towards that. If it's a trauma surgeon, it will not count towards their 50% peer review meeting attendance. If they're absent, they're absent. The only absences that we approve or excuse, if you will, are due to military deployment, medical leave, and missionary work. And either of those instances, if you do have a physician who qualifies for all of that, we will ask you to have documentation at the time of the site visit stating that they are either on military deployment or medical leave or missionary work. Response to question number 2, who else should be get your peer review minutes? Essentially, all members of the trauma panel should do documentation, not necessarily the minutes, but possibly a summary of your minutes, at least anything with any corrective, or in this instance, event resolution. Again, this should be monitored and tracked on how that's being disseminated But again, it doesn't necessarily have to be the minutes per se, but it can definitely be a summary to all your trauma panel members. We obviously review all deaths, whether it occurred here or after transfer, but for the PRQ question, how many trauma deaths were there during the reporting year, and for the purpose of the category deaths for the ACS review, that's for the on-site review, is that only referring to deaths, not deaths that occurred here, not deaths that occurred after a transfer. So super easy. For purposes of the PRQ and the actual on-site visit, we only want to see those deaths that occurred at your facility during the reporting year, and have those available at the time of the on-site visit. So we're not looking to track those deaths that were discharged and happened after they left your facility. Had a question, and I know where this question came from, and there was some confusion last month, but hopefully I can clarify it here. Is screening for PTSD in trauma patients required the same way alcohol intervention screening is required? What tools are available to screen and monitor PTSD in trauma patients admitted greater than 24 hours? Second question, we are trying to understand the PTSD assessments and requirements therein. What is the position of the ACS? So let me just start off by saying it is not a requirement. PTSD, post-traumatic stress disorder, is not a requirement in the Orange Book or in the clarification document. It is essentially a recommendation. It's a should, as it is now in Chapter 18. I know we've had some questions about what kind of tools you can use, and we really don't have any parameters around this. I know on the resources webpage there is, I believe, one example of a tool that can be used for PTSD screening, so you're welcome to use that type of tool or tool rather, and or use any other tool that you deem acceptable. As I mentioned, PTSD screening is not required like alcohol screening. It's noted in Chapter 18 and in the clarification document. PTSD screening should be done on trauma patients that may be afflicted by PTSD. So again, it's just a should. We're not asking you to capture this, but if you happen to see a high volume of trauma patients that suffer from PTSD, it is possible the reviewers will ask you, how are you conducting those screenings and what you're doing for those patients, but it will not be cited as a deficiency. Verification documents, should we have CMEs, ATLS, privileges, etc., in hand at survey for locums who worked a few shifts and or docs who have left? This comes up at every webinar, and I know it's a little different for trauma centers, so I do make it an effort to answer these questions because, again, I do know it differs based on the trauma center. So for those locums that are no longer on the service, basically if they only worked a couple of shifts during your reporting year and they're no longer there, you do not need to enter any of their information in the PRQ or have any of their credentialing process at the time of the site visit. For those locums that are still on the trauma service at the time of the site visit, enter their data in the PRQ and have their documentation at the time of the site visit. So that being copies of their board certification, CMEs, whether external, internal education process, privileges, etc. Just have those in the binders for that service that they're working in, available at the time of the site visit. Orthopedic trauma care. A portion of our orthos, MDs, don't take trauma call, but do end up operating on trauma patients later in their care. Is this okay? So for the person, if they're on this call, I will be following up with you on this because it's a little unclear to me. So I answered it with the thought that if the patient is still under the care of the trauma service, again, I don't know if this particular patient is under the care of the trauma patient or it got discharged to the orthopedic service, but if they're still under the care of the trauma service, those orthopedic surgeons who are providing care to trauma patients must adhere to the same criteria as the other panel members. So CME, LPPE, board certification, privileges, etc. And that is noted in the resources manual on page 60. So again, the answer will differ if this patient is not under the care of the trauma service. So, so if this person's on today's webinar, please reach out to me, or I'll be reaching out to you for further clarification. So we're going to move on to CD-related criteria. So I had a question about 1,200 trauma admissions. Is this referring to actual inpatient admissions or NTTB registry admissions? It is based on the registry admission. So level 1 trauma center admission volume criteria for the reporting year based on the NTTB inclusion criteria with some exceptions in your trauma registry. So that's what we're looking at, your inpatient in hospital inpatient admission, because that number would be way too great. We're looking for just those in your trauma registry. If the ED provider calls the trauma surgeon while he or she is en route to the hospital to notify him/her that they do not need to come, patient died or no longer on site, transfer, do we still count this as an activation? And if so, do we count it as being compliant? So how you count that as an activation, that's going to differ on trauma centers, and that will impact your activation fee. So I think you should definitely go to your either your designating agency to clarify that. However, as I state here, this can be a little slippery slope. You know, although we don't have any requirements around, you know, around this other than if a trauma activation was called, the expectation and the requirement is that the trauma surgeon has to arrive, and this is for a level 3, within 30 minutes. So again, if there's an activation called and it's the highest level of activation, the trauma surgeon is expected to come in within 30 minutes. Now, there is a little leeway there because we're asking for 80% compliance. So if this is happening often, you definitely want to look at your activation criteria to ensure that, you know, this is not something that's going to impact your trauma center or hinge on a deficiency. If the patient expires or is transferred while waiting for the attending, you want to track, monitor, and review those instances through your PIPS process. And at no time do we ever want to delay care for a trauma patient. So, so if your EMS transport service is ready to go and they're at the door and you're still waiting for your trauma surgeon, then, you know, by all means, you want to transfer that patient. And again, you want to make sure you're documenting this on the patient's medical record too, so that way, you know, again, it doesn't hinge on a deficiency for that 80% compliance. And again, again, just PI those instances at your trauma center. Next question, while a trauma doc is scheduled, while a trauma doc is the scheduled backup call, must that doc be dedicated to the facility and the trauma service? So trauma surgeons who serve, who service as a backup are not required to be dedicated to one hospital. So with that said, the trauma center may have to have a 3 or 4 deep backup call schedule in the event that that particular backup surgeon who possibly is at the other facility is encumbered, that you can call another trauma surgeon. You have a schedule for that, because during a site visit, the reviewers are going to want to see your backup call schedule. They're going to want to see a name and a phone number on that call schedule. So again, just be prepared that if you are utilizing a trauma doc to cover a few trauma centers in your region, that you have a backup to that trauma surgeon in the event that he or she is encumbered at whichever facility they're at. My facility is a level 2 adult center. 2017 is the first year that we have admitted 100 kids. I have been reading the Orange Book about the changes that need to be made, and I wondered if you have any direction regarding PACE credentialing for trauma docs. So yes, this is in our book. So if when completing the PRQ, you want to be sure, and I mentioned this a little bit early on, if you admitted any children during your reporting year, let's say prior to that you didn't admit any kids, but now you're seeing an increase in pediatric admissions, then that definitely will change your PRQ going into 2017, or 2018 rather. So your PRQ is going to be an adult and children's level 2 if you have 100 kids. With that said, as a level 2 trauma center that is not seeking pediatric verification, because you don't have to do that, but if you're in a level 2 trauma center that is seeing a high number of children, whether it's 2, 3, 100, 150, or 100 in this instance, and are admitted to your trauma service during the reporting year, the program is required to credential the trauma surgeons. That's the only criteria we're holding for trauma centers that admit 100 pediatric patients or less. Now, examples of the credentialing process can be one of the following. They can have PALS, Pediatric Advanced Life Support. It could be through Pediatric Trauma CME. It could be completion of a Pediatric Trauma Fellowship, or Pediatric Fellowship in this case, or documentation of performance as measured by your PIPS process. So the credentialing process will vary by trauma center. So these are just a few examples. You can implement your own credentialing process for your pediatric surgeons. On the December webinar, the topic of transfers was presented. I just need to confirm the NCDB does not count transfer in from centers that are not considered hospitals to be transfers, but you are saying for verification they are considered transfers and must be reviewed through PIPS process. So there is a little difference in some of how we interpret transfers between TQIP and verification. So often you will see me in my slides say for verification purposes, and the reason I do that is because there is some differences in capturing data, and we are working in our revision process to consolidate that or make them uniform. So, so in this instance, for verification purposes, and completed the PRQ, patients who are transferred in or out to or from another facility, whether that is a sister hospital, freestanding ED, or satellite ED, we call them, private physician's office, etc., are considered interfacility transfers. Again, I know NCDB/TQIP calls it, they don't call it a transfer in, but for verification purposes, that is our definition. On level 2 activations, when a trauma surgeon is consulted for admission, what is the required time for them to arrive to the ED? So again, this is talking about the limited tier activation. You can call it, in this case, they called it a level 2 activation. We call it a limited tier. The name varies. It can be called anything you want. The institution will define or establish the time and the injury or injuries expectation for when the trauma surgeon is expected to arrive for your limited tier. So if, so most centers have a metric between 2 to 6 hours, some have 12 hours. That again will be defined by your institution, and again it may be impacted by the type of, it may be impacted by the mechanism of injury. So most importantly, you want to make sure that you're following your metrics, the metrics that you've established at your trauma center through your PI process. So for the limited tier activation, the college or even the verification does not define what that time is. You, along with your trauma medical director and your ED and your trauma surgeons, will define what injuries you are expecting your trauma surgeon to arrive and to see at bedside. And what the reviewers are going to do when they come on site is they're going to ask you to see that policy, and they're going to want to know through your PI process if you're adhering to it. And if you're not adhering to it, if you don't have a time, because I've seen this recently come up in a few reports, and they've been cited deficiencies. You want to make sure your limited tier plan has a time of when you expect your surgeon to come in, along with the type of injuries you expect that surgeon to arrive. So again, make sure that is written in your policy/protocol/plan. What are the reviewers' thoughts on having mechanism of injury in your lower tiered activation criteria? This is a level 3, so I'm going to refer you to page 39 of the resources manual. There's a table that provides examples with the types of mechanisms that are acceptable, and again, you can expand on that. This is just an example of the type of injuries that that you can have, but you can certainly add more. I was left very confused by one of the answers to the questions in the December webinar. It was stated that for the 30-minute response time for neurosurgical patients, it is okay for the resident or APP to be the first responder, but that there must be a clear discussion of the plan of care within 30 minutes with the attending neurosurgeon. In reviewing both the Orange Book and most recent clarification document, I see this requirement for orthopedic response, but nothing like this for neurosurgery. Can you please clarify? So let me first clarify a sentence in this question, which is not correct, which is, it stated that there must be clear discussion of the plan of care within 30 minutes with the attending neurosurgeon. It's really not that you have to have that discussion within 30 minutes. It is that you have to have a response at bedside by that specialist within 30 minutes. So I just wanted to clarify that. And furthermore, let me clarify, the intent is that the trauma medical director and liaisons for either the orthopedic or neurosurgery develop guidelines for which types of critical and complex injuries the orthopedic or neurosurgeon will respond to in person within 30 minutes. With that said, if they send a specialty resident, that being the orthopedic or neuro, PA or APP, then there should be guidelines for the type of injuries they're going to respond to. And again, that's got to be approved by the trauma medical director and the liaisons. And then again, the second part of that is that there must be clear documentation of the discussion with the surgeon specialist of the plan of care. So the requirement is 30 minutes within with a notification, and again, approved plans for what types of injuries the residents, PAs, and APPs will be responding to versus those that are critical, where the orthopedic and neurosurgeon will be required to respond. Please clarify CD 1117. Are we timing from the first call to OR by surgeon to the incision time to enter OR time? So this is regarding the start time for the operating room response. And again, this is noted in the clarification document. The clock starts from the time the OR is notified that a case will be done. That's what we're not doing it from incision time. I just wanted to clarify that. At a level 2 trauma center, is it okay for the ICU director or co-director not to be board certified in surgical critical care? Absolutely, that is acceptable. The requirement is that one of the two, either the director or the co-director, be board certified, be a board certified general surgeon. It does not need to be a board certified in surgical critical care, but it definitely has to be a board certified general surgeon. Currently board certified, I might add. Do ICU physicians need to be in-house if they can meet the 15-minute response time? Again, I will refer to page 81, table 1 in the resources manual, where it states for level 2 trauma centers, the coverage by the credentialed provider must be available within 15 minutes. How and where they're coming from will be determined by the trauma center. It does not stipulate in-house, but if they can get there within 15 minutes from where they're at, then you're meeting the metric, the requirement rather. Alcohol screening, explain the alcohol screening requirement. All patients are asked if they use or not, and offers resources. Is this enough? And this is for level 3. And there was a second question. Recently, clarifying document states ESPER to include activations or all admitted trauma patients. Is this a choice? It is not a choice. And I'm sorry if that was written somewhere. I couldn't find that it said activations or admitted patients. So the way it's interpreted, or the way it reads, is for level 1, 2, and 3 trauma centers, there must be a process, mechanism, which is a tool, and documentation for patients who meet the NTDS inclusion criteria, whether activated or not activated, for trauma patients that are admitted with a hospital stay greater than 24 hours, of which 80% of those patients must receive a screening. So that is how it's been clarified. Again, activated or not activated, we're talking about patients who are admitted. So if you did not have a patient that was admitted and they were discharged, we're not looking at that population. And I do want to clarify for level 1 and 2 trauma centers, this is for the second question, all patients who have screened positive must receive an intervention by appropriately trained staff. And this intervention must be documented. So for level 3, we're not asking for intervention. For level 1 and 2, we are, and it must be documented. Can the expert duties be part of social work, or does it need to be trauma such as CPM or injury prevention job description? So we have never said that it has to be the trauma program manager, injury prevention coordinator. It can definitely be the social work. So in level 1 and 2 trauma centers, the screening may be performed by someone in social work. The trauma center will define the training, the skills, and the experience for what constitutes appropriately trained. So if that's your social worker, that's great. If it's someone who is has education or experience in expert, then that's also acceptable. So we're going to go ahead and move on to a couple of questions about CME. Internal and external examples. So if someone asked if we have an extensive list of CMEs that fulfill the trauma requirements. We are working on trying to come up with a list of what are acceptable external trauma-related CMEs. We don't have this right now, but we are going to try to kind of come up with something and make it easier for all the programs. So I do want to say that there are some examples within the book itself, within each of the chapters, which that is trauma surgery, emergency medicine, neuro, ortho, and the ICU sections that provide some examples. And as noted here, it could be in-service, case-based learning, educational conferences, grand rounds, internal trauma symposium, in-house publications, etc. So there's some examples here that you can utilize. As for external, again, I have brought back a couple of slides that I did early on in 2016 with some courses, and so that will, I'll definitely increase that as time goes on, but I just wanted to bring that back here for a presentation, so you certainly can, you have something to gauge. So again, this is from the August 2016 presentation. So I had a question, actually this is a question more recent though, but I did bring the response over. Can you please list out CEUs for courses that were offered for certain classes, ATLS, PALS, ACLS, etc. There was a chart before, and again, that they're right, the chart came from the 2016 webinar. So again, this is just a quick snapshot of what the ACS college courses offer, and this will definitely increase over time. I do not have the ATLS 10 yet on here, but that will be forthcoming. Again, just a quick snapshot of what the ATLS courses offer. The 10th edition, I'll have that when I have that information from the ATLS team. Critical Care Board Certification. Does taking General Pediatric Board Research Exam count as 33 hours of CME for my Pediatric Critical Care MDs? Yes. So whether it's critical care, general boards, and pediatric or general surgery boards, that definitely will count to meet the 33 hours of CME requirement. Pediatric verification, how many pediatric trauma CMEs are required for physicians in a pediatric level 2 that is being verified in May of 2018? Again, this may vary depending on when the physician started, but if this is a new trauma center that's asking this question, for new trauma centers seeking verification for the first time, CMEs will be prorated at 16 hours for the year. Of those 16 hours, we're asking that 4 must be pediatric trauma related, and that is also in the book and in the clarification document. So if it's a pediatric trauma center, we do want to see some pediatric specific trauma CME. If pulmonary critical care is consulted for vent management only, does the med critical care physician need trauma-related CME? No, they do not. We only want CME for patients who are under their care. So if the pulmonary critical care physician is only providing vent management, they are not required to meet the CME requirement. Please clarify, do trauma surgeons on the call panel have to have 12 hours of pediatric CME or only medical directors and liaisons? Second part, or another question that came in a level 1 pediatric trauma center, what is the CME expectation for pediatric ICU attendings who staff the PICU 24 hours a day? The answer to these two will not differ. If seeking pediatric re-verification, the trauma medical director and the liaisons have to accrue external trauma-related CME, of which 12 hours, of the 48 hours in 3 years, 12 must be clinical pediatric trauma care, related to pediatric trauma care. Now, for the other panel members, so again, trauma medical director and your liaisons have to have external trauma-related CME. For the other panel members, they can have a mixture of external, internal, or internal via internal education process of 48 hours in 3 years. And again, 12 have to be related to pediatric trauma care. So it's the same for these two cases. Again, the differences is what's required externally for the trauma medical director and liaisons, and those internal, and those for the other panel members, which could be a combination of any of those. Our CME is still prorated based on start date of hire. Clarification documents as new physicians. And I know this is a little confusing for a lot of trauma centers, and I know it's not clearly written in the clarification document, so hopefully what is written here will clarify a lot of the questions that we get about new grads and new hires. So as you know, the requirement is 48 hours. Leading up to the site visit over the 3 years. On average, it's 16 hours per year, but how those 48 hours are gathered, that's really going to depend on that physician. It's one way, again, is doing it every year, 16 hours, or they can do it in 1 year. It's really their call on how they want to do that. We're just expecting to see 48 hours during the site visit. For new members to service, it would be expected that they have the required CME, since they are more than likely coming from another trauma center. So if for some reason they do not, because they were brought on in the middle of the review cycle, then at that time it will be prorated based upon their start date. So again, if you're hiring new trauma surgeons, ideally they're going to come with their own CMEs. And you can use that because they're, if they're done within the 3-year report or during the 3-year cycle. For new graduates, should begin the process to acquire CMEs right away. However, if again they are brought on midway through the review cycle, meaning your 3-year period, their CME would then be prorated based on their start date. So one of the things we don't provide CME for their residency, so we do get that question often, so I just wanted to clarify that. We have an emergency center physician, not trauma liaison, but cares for trauma patients in the emergency center, who started the facility July 2017. He is a new graduate and is requesting how much CME can be counted from his schooling, and 2, can his CME requirements be prorated from 16 hours to 8 hours? So Again, we do not accept medical school to count to meet the CME requirement, nor residency, medical school / residency. We don't count that as CME or as an acceptable way of CME. If he, the resident, came on the service July 2017, and depending on when the center's visit is scheduled, CME will be prorated based on when he came on the service. So again, it's prorated when they came onto your service. Internal CME, for level 2 trauma centers, you have to have an internal education process and must it equal 16 CME. No. So the short answer to this is you don't have to have an internal education process. So it was a way, I guess I don't like to use the word alternate, but it was an alternate way for your other trauma panel members to meet the CME requirement. So an internal education process is not required at a trauma center. However, that means that your trauma panel members have to have external trauma-related CME in order to be compliant with the requirement. Again, the trauma medical director, if you do have an IEP, the TMD and liaisons have to have external. But if you do have an IEP, then your other panel members can certainly meet the requirement that route. So for a level 3 trauma center, do neurosurgeons have to have 16 hours of trauma education? And so level 3 trauma centers are not required to have CMEs. We're not asking for CMEs for any of the subspecialists or trauma surgeons at a level 3 trauma center. And that will conclude our presentation today. So I'd like to thank everyone for participating in today's webinar.
And thank you, Trauma Verification staff, and thank you for everyone for attending today's webinar, Trauma Verification's January Q&A web conference. If you have any other questions, please contact cotvrc@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today and have a great rest of your day.